All right, good morning again, everyone. This morning we're going to be discussing cranial nerve palsies that affect the eye. As usual, we have a pre-lecture quiz which has been up for a little bit, so you had a time to peruse these questions, and so afterwards, hopefully, you can answer these questions. So just a quick recap. As we said, you have extraocular muscles, including the medial, inferior, lateral, and the superior recti. And you have the superior and inferior obliques. Most of the recti originate from a fibrous tissue at the apex of the orbit called the annulus of Zinn. The innervations of the recti are mostly from the third cranial nerve, with the exception of the lateral rectus, which is innervated by the sixth cranial nerve, and the superior oblique, which is innervated by the fourth cranial nerve. We discussed at the last meeting the direction of pull and the action of the muscles and the field of action of the muscles, which we paid a little bit more attention to. We said your superior rectus would move the eye superiorly and laterally, whereas your inferior rectus would move it inferiorly and laterally. Your lateral rectus would abduct the eye. Medial rectus would adduct the eye, adduct, and your obliques would move the eye, inferior oblique would move the eye up and in, superior oblique downwards and inwards. And if we look at this picture of the eye, we can see that this is the eye in primary position, and then we have some cardinal positions, positions, 6 of them, 1, 2, 3, 4, 5, 6, and then the midline vertical position. So if the person is looking up and towards the right, then the right eye would be acted on by the superior rectus, whereas the left eye looking up and in would be the inferior oblique. Over here, if the person was asked to look up and to the left, then the right eye would, the inferior oblique would be responsible for that action, where left it would be the superior, etc., etc. We're going to start by discussing the oculomotor nerve, which is a third cranial nerve, which is entirely motor in function. It supplies all the extraocular muscles except the lateral rectus and the superior oblique. It also supplies the sphincter, pupillae, and the ciliary muscle. The nucleus lies in the midbrain at the level of the superior colliculus, and the motor nucleus has 2 motor nuclei, a main motor nucleus and an accessory motor nucleus that we call the Edinger-Westphal nucleus. Now, the main motor nucleus is composed of subnuclei supplying the individual extraocular muscles. The levator subnucleus is unpaired. It's a single nucleus that innervates both levator muscles, and thus if you have a nuclear third nerve, then both your levator muscles would be affected and you'd have bilateral ptosis. Your superior rectus subnuclei they are paired and each innervates the contralateral superior rectus. Your medial inferior rectus and inferior oblique subnuclei are paired and they will innervate their corresponding ipsilateral nucleus. The Edinger-Westphal nucleus is posterior to the main oculomotor nucleus and it consists of a median and 2 lateral components. The cranial half is responsible for the light reflexes. whereas the caudal half would be responsible for accommodation. Now, when the third nerve exits the brain from the nucleus, it passes through the red nucleus, and then it passes through the corticospinal or pyramidal tract, and it passes in the interpeduncular space. It passes between the posterior cerebral and the superior cerebellar artery, and medial to it is the posterior communicating artery, and then it will be the cavernous sinus. There are certain lesions that are of interest. At the level of the red nucleus, you can have Benedict syndrome, which will cause a contralateral hemitremor with the ipsilateral third nerve paresis. Naegeli syndrome is at the level of the superior cerebellar peduncle. Then there's Claude syndrome, and Weber syndrome is at a lesion at the level of the corticospinal tract, which involves the ipsilateral third nerve paresis with contralateral hemiparesis. If you have an aneurysm of the posterior communicating artery, this will present acutely as a pupil involving painful third nerve palsy. If you have a subdural or an extradural hematoma, it may cause central pressure on the cone with downward herniation of the temporal lobe. This may compress the third nerve as it passes over the tectorial edge. In the lateral wall of the cavernous sinus, the third nerve is gonna run above the fourth cranial nerve. It divides into a small superior division and a larger inferior division before it enters the superior orbital fissure, which is a fissure between the posterior part of the lateral wall, roof, and medial wall of the orbit. Of an intracavernous third nerve palsy include diabetes, pituitary apoplexy, aneurysms, meningiomas, carotid cavernous fistulas, and granulomatous inflammation. Now, the superior division of the third nerve is going to supply the superior rectus and the levatus palpebrae superioris, whereas the inferior division is going to supply the medial inferior rectus, the inferior oblique, and it will send some innervation to the ciliary ganglion. So the fibers that are going to supply the pupil, or the pupillomotor fibers, are parasympathetic, and they're located more superficially in the superior medial part of the nerve, and they're going to derive their blood supply from the PL blood vessels. The main trunk is supplied by the vasa nervosum. So surgical lesions such as aneurysms, traumas, or uncal herniations are usually pupil involving, whereas medical lesions such as hypertension and diabetes are going to spare the pupil. Here's a pictorial of that. As I said before, your pupillomotor fibers are more superficial in the nerve, and therefore the blood supply is coming from the PL vessels. And if you have an aneurysm or a compressive lesion, then it's going to affect the blood supply to the pupillomotor fibers, and therefore you're going to have a pupil involving third nerve. However, when you have diseases such as diabetes and hypertension, then these are going to be affecting the vasa nervosum that do not supply the pupillary fibers. So you'll have a pupillary sparing third nerve palsy. So the signs of a third nerve palsy are profound ptosis, weakness of the levator muscles, abduction and depression in the primary position, so the eyes down and out. There's unopposed action of the lateral rectus and the superior oblique muscles. There's normal abduction, but there's limited elevation, depression, and adduction. So as you can see in this picture here, there's profound ptosis of this right eye. When you open the eye, and if you compare the light reflexes as we showed last week, you can see that this eye is down and out. When you ask him to adduct the eye here, you can see that whereas his left eye moves outward, his right eye cannot move forward. So he cannot adduct that eye. That's limited right there. Here's another pictorial. Here you can immediately see that the right eye here, there's ptosis, there's marked ptosis, and the eye is down and out. And in this next picture, you can see the left eye is involved. There's marked ptosis. And when you open, you can see there's a bit of anisocoria where this pupil is involved. This pupil is dilated. Here's another picture where you have marked ptosis here. So this eye is involved, and she had limitation in adduction of that eye. When you looked at her pupils, a little hard to see, although she has cataracts, you can see she has anisocoria where the involved pupil here is a bit dilated and the pupil on the right is smaller. And this is an actual patient of whom we want to do an MRI, and she did have an aneurysmal lesion there. We're going to talk about the fourth cranial nerve, or the trochlear nerve, and the nucleus of the trochlear nerve is at the midbrain at the level of the inferior colliculus. Now this is the only cranial nerve that comes from the dorsal aspect of the midbrain, and it crosses completely to the opposite side. And so the trochlear nerve will arise from the contralateral nucleus. It passes between the posterior cerebral and the superior cerebellar arteries. Then it ends in then it goes to the lateral wall of the cavernous sinus below the third cranial nerve, and from there it moves on to supply the superior oblique muscle. So if you have an isolated fourth cranial nerve palsy, it may be congenital or acquired. There's usually a hyperdeviation, so one eye is above the other. Depression is limited in adduction, and intorsion is also limited. So the person will complain of double vision when looking downwards. There's usually an abnormal head posture. So to avoid the double vision, the head takes up an abnormal posture towards the action of the superior oblique muscle. So the face is turned to the opposite side, the chin is depressed, and the head is tilted towards the opposite shoulder. So here we have a picture just demonstrating this. So if you look in the center picture here, you can see that this right eye seems to be a little bit higher than the left eye here if you just look at the pupillary reflexes there. All right. When he looks to the left side, to the opposite side, you can see that the deviation appears even worse on that when he looks there. All right. And then when he tilts his head to the right, you can see that the deviation appears worst there as well. So these are just some tests that we do to confirm a fourth nerve palsy. You don't need to worry about that. So here we have a little kid who also has a fourth nerve palsy, which you can see in the second picture here. It's even worse when he looks to the right. The sixth cranial nerve is an entirely motor nerve which supplies the lateral rectus. The nucleus is located in the lower part of the pons, and it exits between the pons and the medulla at the level of the pyramid. It passes inferior to the inferior protrusal sinus and runs vertically up the back of the petrous near the temporal of the petrous temporal bone near its apex. From the cavernous sinus, it runs to the superior orbital fissure, and then it innervates the lateral rectus. The nucleus lies at the pons and it leaves the brainstem at the pontomedullary junction, and therefore there are some syndromes that you can see here. In a nuclear lesion, you can have facial nerve, the seventh facial nerve, the cranial nerve 7, which is a facial nerve, wraps around the sixth nucleus. And so, along with a sixth cranial nerve palsy, you'll have an ipsilateral lower motor neuron facial nerve palsy in a nuclear sixth cranial nerve. Foveal syndrome is another syndrome where you can have involvement of multiple cranial nerves from the 5th through the 8th. You will also have Horner syndrome and horizontal gaze palsy. And Millard-Gubler syndrome involves the fasciculus as it passes through the pyramidal tract, usually secondary to demyelinating lesions or vascular lesions. You may have a contralateral hemiplegia and an ipsilateral lower motor neuron facial nerve palsy. And this is just a diagrammatic representation showing you your Millard-Gubler syndrome here, and over here your foveal syndrome, which will affect several cranial nerves. The basilar portion of the sixth cranial nerve enters the basilar cistern and passes close to the base of the skull before it pierces the dura. It angles sharply forward over the tip of the petrous bone before it passes through the petrosal sinus to enter the cavernous sinus. And this is a picture of the course of the nerve, as you can see here. In an acoustic neuroma, you may have damage to the sixth cranial nerve at the pontomedullary junction. In nasopharyngeal tumors, it may invade the skull and its foramina and damage the nerve during its basilar course. In raised intracranial pressure, it may cause a displacement of the brainstem, and this may stretch one or both of the sixth nerve over the petrous tip, and this paresis is thus a false localizing sign. In a basal skull fracture, it may cause unilateral or bilateral palsy. In this pictorial here, you'll see that, the diagnosis I should say first. The person may have double vision, which is worse for distant objects. They'll have esotropia in primary position due to the unopposed action of the medial rectus. The deviation is usually worse for distance than near. There's limitation of abduction, abduction, and there's normal adduction, adduction. They may have a compensatory face turned towards the side of the paralyzed muscle. And you should also always examine all the cranial nerves whenever you suspect a cranial nerve palsy. So in the upper picture here, we see that the left eye is adducted, and when you ask the person to look to the left side, we notice that the eye cannot move, it's fixed, whereas the right eye moves quite fine. So what are some of our differentials here? It could be secondary to thyroid eye disease, which I think you had a wonderful session yesterday about. Myasthenia gravis. Duane's syndrome is a horizontal, is a syndrome with a horizontal gaze palsy where you have poor development of the sixth cranial nerve, and therefore the third cranial nerve innervates both the medial and lateral rectus. So you have different types of Duane syndromes, but in Duane's type 1 syndrome, you'll have an esotropia. If you have a medial wall blowout fracture with restrictive myopathy, then you may also get this picture. The fifth cranial nerve has both motor and sensory nuclei. The motor nucleus is in the upper pons, and the sensory nucleus is the trigeminal ganglion, which extends throughout the brain stems and descends into the upper two or three segments of the spinal cord. There's a mesencephalic nucleus, which is responsible for proprioception, pontine, which is responsible for good sensations, and medullary nucleus, which is responsible for not so good sensations. The anterior half of the trigeminal ganglion gives sensory divisions, V1, V2, and V3. In ophthalmology, the ophthalmic division is the first division, which is V1, which is what we really focus on. So I'm sorry, there went a little too fast for you. So the ophthalmic division picks up sympathetic fibers from the cavernous plexus for the dilated pupillae. The lacrimal nerve innervates the lacrimal gland and the upper eyelid. The frontal nerve and the nasociliary nerves are also branches of the first division. The maxillary division supplies the maxilla and the mandible, which we're not interested in that much in ophthalmology. The seventh cranial nerve is the facial nerve. It has both motor and sensory nuclei. The main motor nucleus is located in the pons. The upper part of the face receives cortical nuclear fibers from both cerebral hemispheres, and the lower part of the face receives cortical nuclear fibers from the opposite cerebral hemisphere. It has a parasympathetic nuclei and sensory nucleus as well. Lesions of the facial nerves may be supranuclear. It may be located at the cerebellar pontine angle. We may have a Ramsay-Hunt syndrome or Bell's palsy. If we have a supranuclear lesion, only the lower half of the face is involved. Remember that the upper half of the face has bilateral innervation. For cerebellar pontine angle tumors, there's usually total ipsilateral facial weakness, decreased tearing, decreased taste from the anterior 2/3 of the tongue. The fifth, sixth, and seventh nerve can be involved with cerebellar dysfunctions. For Bell's palsy, this is a common type of facial neuropathy, but it is a diagnosis of exclusion. Patients will present with sudden onset of facial paresis. The pain may precede a palsy or it may occur concurrently. Most of the times, the etiology is unknown, but it can be secondary to an autoimmune or virally induced inflammatory ischemic injury with swelling of the peripheral nerve. The external ear canal should be examined for vesicles because it could be secondary herpes zoster, in which we call the syndrome of a Ramsay-Hunt syndrome. The incidence is higher in pregnancy, in diabetes, or a family history of Bell's palsy. If the facial weakness progresses over 3 weeks, then you have to check for a neoplastic etiology. Most recover spontaneously. However, if we see them within 72 hours of presentation, then we can give steroids as part of the treatment regime to speed up recovery. With Bell's palsy, one of the serious ophthalmic complications that can occur is exposure keratopathy. So the cornea may be exposed, and we have to be careful here because corneal exposure can lead to corneal ulceration, and ultimately the patient could lose the eye. So if there's severe exposure, they should be referred on to ophthalmology, where we may do minor things such from taping the lids closed, lubricants, or we may surgically intervene with temporarily suturing the lids closed or other interventions. Other non-surgical interventions for Bell's palsy or anyone with exposure could include goggles, or we can make cones so that we can reduce the desiccation of the eye. All right. So welcome, Jabari. Can you describe the picture that you're seeing there, please?
So I see if Mark was unable to open the eyelid of the right eye, so I'm sure that would be marked ptosis. And the left or a mild deviation of the right eye away from the midline, and then I think I'm not sure if it's the left eye that's looking to the left, the right eye when it comes to the midline.
Jabari, your audio is, we're not hearing you well. So
Oh,
no, you're breaking up a lot. So I'm gonna ask Carlos Andrew if he can take over from you because we couldn't hear you. Sorry about that, Jabari.
Hi, good morning. Hello?
Good morning.
Okay,
Hello.
As Jabari said, the right eye is unable to open, so ptosis, and the left eye is normal. The right eye is downward out, deviated downward and outwards, and is unable to look to the left. So I assume it's an oculomotor cranial nerve palsy.
Okay. So what's your diagnosis?
Cranial nerve palsy number
Can
3.
you hear me clearly?
Yes, that's up.
Can you hear me clearly, Carlos?
Yes.
Okay, because you're all sounding a little bit, you're breaking up a little bit. All right, so you're thinking it's a cranial nerve 3 palsy.
Yeah.
All right. Um, what salient points from the history would you like to know?
Um, if they had a history of trauma.
Okay. So you're saying that this could also be a traumatic ptosis, which is true. But if you looked at this patient and you saw not just the ptosis, but you're seeing that the eye is down and out, as you said, and you say it's a cranial nerve 3 palsy, what else can you, what are some of the etiological factors?
Aneurysm or diabetes.
Yes, you could ask of diabetes and
or hypertension
hypertension,
or
but
a neoplasm.
well, how, all right. Um, you would ask of pain. Would you ask about headaches as
Okay,
well?
yeah.
Yeah, because that would clue you in that there's something intracranial going on. All
Hmm.
right. And if you examine the pupils and you notice anisocoria, what would be your next step? Would you do
Um,
an investigation?
I came in late, so I probably missed that. So I'm not sure.
Pardon?
I said I came in late, so I probably missed that.
No? So you definitely should have gotten that. All right. Dale, do you want to help Carlos out?
Doc, can you repeat the question, please?
So this patient who is shown here, he adequately described the patient as having a complete ptosis of the right eye with the eye down and out, and he thinks it's a third nerve palsy of the right eye. Now we examined the pupils and noticed that the person had anisocoria, which means a difference in the pupil sizes. So his right pupil was much larger than his left pupil. So the pupil over here in this eye was much larger than this eye over here. The person has headaches, severe headaches. So this person is having a painful third nerve palsy. What kind of investigation would you do?
Hello.
Yes, I'm here.
Um, so I'm thinking you might want to do some sort of imaging. You could do
Right. So you image the, mhm. That's correct. So we do some neuroimaging. Um, so we can do an MRI or an MRA. Thank you very much for your participation, Dale. All right. So we have Jessica. Hmm. Good morning, Jessica.
Hi, good morning. Okay, so the first picture, the second picture, and the third picture. So it seems as though the patient's being asked to follow a moving target. So the left eye seems to not be able to look to the left. So it means that the lateral rectus of the left eye isn't working. So, mm, so it could possibly be cranial nerve of trochlea. So the trochlea nerve isn't uh, doing its job. Okay. So cranial nerve 4 palsy. Sorry, 6. Sorry. Cranial nerve 6 of
Oh,
the. Sorry. Hello? Am I? Um,
yes, you gave me a fright just now.
oh,
Right, so you corrected yourself.
yeah. So, yeah,
So it's
sorry.
the sixth nerve of which eye,
Of the left eye.
of which
Of the left.
of the
Of the
left.
left eye. So
All right,
it's.
so this is the patient looking straight ahead. We're gonna say this is the right eye
Mm-hmm.
and this is the left eye. So the patient was asked to look to the
To the
left
left.
and the right eye adducted, but the left eye would not abduct. And when he's asked to look over here, the right eye would abduct and the left eye would adduct. So we conclude that here's the problem, the left eye, which cannot abduct. And so that's a left sixth nerve palsy. Was that clear, Daniel? Drakes or Twiddle? We have two
Yes,
Daniels. Pardon?
yes, it was clear.
All right, so the next question is yours. Which one is it? These are easy. All right, Daniel, quickly. True or false? The lateral rectus is innervated by the third nerve.
False.
Continue. The superior oblique is innervated by the fourth cranial nerve.
That is true. The third one is, I would say true because it said if it were hypertension or diabetes, it would affect the vasorum and not the pupil, if I remember correctly.
Okay,
The
that's
fourth
true.
one,
So the fourth one, and then
that
I'll give you a break.
that one is also.
All right, so let's see who else is here. Chantel, can you take the next question, please? Chantel, are you here?
Hi, good morning, Doc.
Good
Here
morning.
to question 4.
I think it's question 5.
Okay. Alright, cranial nerve 3. That would be true.
That is true. How about the next one?
Cranial nerve 6 will be caused by, well, it can be caused by, yes. I know that it can be caused by trauma.
So is that true?
Which would,
Are you saying it's true?
I'd say it's true.
That thing is true?
That number 6 is true, yes.
Yes, it's a focalizing sign. All right. Are there any questions from the group? I think most of you sounded from my end as if you were breaking up just now when I asked the questions. Most of you sounded a bit dodgy. Yeah. All right, so are there any questions? Did everyone understand? I think this is one of those lectures that you're gonna have to go read and just look back at the topic and just be fluent in your speech when you're describing. There are certain things you can't miss in an exam, and we stressed so much. Even if you came in late, I've or 3 palsy, because this is something that can be life-threatening. All right. You don't want someone with an aneurysm to be walking around, especially if it's a surgical third nerve. They need to be referred to the neurosurgeons as soon as possible. So this person has a profound ptosis We're gonna speak the next time about something else. So I want you to really cement this so that when I talk about any other type of ptosis and anisocoria, you don't get confused. This person has a profound ptosis. So it's a really profound ptosis that this person has. And the eye position is down and out. And the pupil on the involved side, on this side here, which is involved, is gonna be dilated, all right? So you can't forget that, all right? We have said this so many times. 6 nerve palsies, yes, it can be secondary to diabetes, hypertension, dyslipidemias, etc. However, you may also have to rule out your non-benign lesions in these cases as well. 4th nerve palsy is usually maybe congenital, but in an adult, it's usually secondary to trauma, motor vehicle accidents. So it's just a matter of rereading the information and you should be fine, all right?